Amazingly. I'm going to tell you a little bit. I graduated from Boise High School in can I say it? 1977. My goodness. And but I headed to the state of Washington to go to college, and I just ended up staying here. Met my wife in college, the classical story, but I just stayed on. I did my master's in Seattle and stayed on, did my doctorate. And we had a vision for something called the Center, a Place of Hope, which I'll tell you about. My background is in counseling and health psychology. And I have to tell you that when I was going to school, I really wasn't sure about psychology. I thought, my goodness, some of this, there has to be more. And we had an early vision for building what we called the whole person approach in the early 80s. But before we got to that, I spent a couple years doing sleep research at the University of Washington. So we were studying back in those days issues of sleep and how it affected our emotional well-being, and really beginning some things that hadn't really been looked at too closely. But my job there as an assistant researcher was to stay up while other people slept. Isn't that an amazing job? And there at the University of Washington was the um, health sciences building. We had a sleep lab, and we had cadavers on the other side, cadavers for the medical students, a room full of cadavers. And on the other side of the sleep laboratory was where they had the primates, the monkeys, monkey testing. And here's the sleep lab in the middle. And if you can imagine, I'm there with people when we're studying their sleep during the night. I got cadavers on one side, and I got the monkeys on the other side of me. And whoever designed this was, I don't know, but um, that was the beginnings of some early research as it relates to sleep and our emotional well-being. Today, here at the center, excuse me, we do sleep studies on most all of our patients who come to us, which I'll talk about in a minute. But we know that we've got to cover all the bases. From the sleep lab work, I actually ended up working at a women's prison. I
Wow.
spent I spent 2 years working at the women's prison in Washington State. Now, if you can imagine, this is a few years ago. Um, I'm assigned to. It's choking me up. I'm assigned to the special needs section of a women's prison. Can you imagine having a job being assigned to what was called the special needs section of the women's prison? This basically was the area of the prison that was in the center of the compound. It was what they categorized as the roughest and toughest and meanest women, and that was my initial assignment. And I need to tell you that there was a lot of eating disorders in the women's prison. We had a lot of anorexia, self-starvation, and we had really, it was a slow suicide for many. It was a way of getting out of planet Earth, committing suicide ultimately. And it was really there that I began to look at because there really wasn't good treatments for eating disorders. In fact, the medical literature early on said that eating disorders were cunning and baffling, and nobody knew really what to do for eating disorders. So we went on a really after that an adventure to figure out what do you do to help somebody with anorexia, bulimia, compulsive overeating. And we founded the center, a place of hope now. This year was our 36th year. And it sounds awfully strange to say 36 years because I am still very passionate, excited about our work and what we do. But began to work with the eating disorders, and we worked with all ages. And the youngest age that we ever have worked with an eating disorder, amazingly, is age 9. If you can imagine somebody suffering, a young girl with an eating disorder at age 9, choosing not to eat. And so, because of the work that we had done, this particular family had taken their daughter. to places, hospitals, and treatment programs where they were actually putting her, excuse me, in restraints and force feeding her. Now, can you imagine a 9-year-old girl in a hospital being put in a straitjacket in restraints and being force fed as a treatment modality? We're going to make this girl eat. She's not eating. And you can imagine if any of us did that today, we'd be in trouble for it. But that was a treatment modality, tying a person up, force feeding them to treat them for an eating disorder. This young girl had been IV fed, nasal tube fed, and for whatever reason, she was choosing not to eat. We were given our team came together again. We treated a lot of eating disorders and had a good reputation for treating eating disorders. And we really had to come to a place of agreement and understanding as a team. We do everything as a team here, that we were going to take this young girl on. And we did. Her family brought her from Alaska. She arrived obviously severely underweight. And this young girl, the traditional treatments obviously had not worked. We were very concerned about her staying alive. And we actually had a special room that we had put her in, and the assignment we gave our counselors were to enter into her world, make eye contact, enter into her world. Because she had been in so many hospital programs, they stopped touching her. She wasn't receiving any hugs. She was used to people in white lab coats. And one of the things that was happening was she wasn't receiving any affection or love. And so one of the things that we did early on was we were going to get on our hands and knees on the floor and be with her. And I share this story because this shaped our whole person philosophy, and a philosophy that we have that I'll share more about our why not philosophy. I was driving home day 2 that she was here, and we were all very, very concerned about her. We could get liquids, and she would receive liquids, but she just wouldn't eat. And I drove past a veterinarian office on my way home. The veterinarian office had a sign up that said free kittens. And so I pulled in, and I went into this vet, and he was just closing, and I inquired about having a free kitten. He said, well, I don't think it's the one you want. It is a kitten that is the runt, and he says, I'm not even sure it's going to live. And I said to this vet, I said, you know what, that's the perfect one. That's the one I want. And so he gave me this little kitten that would literally fit on the palm of your hand. And I took this little premature kitten, and I took it back to this young little 9-year-old girl. And I said, sweetheart, your job is to keep this kitten alive. And no kidding, she held that. She petted and petted. And we kind of had a joke that she's petting this kitten so much she's going to rub the fur off of it. And it was just a couple days later, while we were in this special room and she was with one of our treatment team members, that she looked up and she asked for food. Now, nobody had ever remembered when this young girl had ever actually asked for food. She'd been force-fed, she'd done all these things, but she'd never, ever had asked for food. And so our counselor came, I remember the day our counselor came running out of this special room we had set up. And he said, she wants food. What shall I do? And I said, go back in and ask her what she'd like. And by our definition of food, she was asking for Pop-Tarts and a few other things that I don't know that I would classify as food, but we went and got her exactly what she wanted. And we sat down with her, and that was the day that she began to eat. And we began to look at what's going on here. She's had a little premature kitten that we told her assignment was to keep it alive. She's been petting it and petting it. And we began to look at a different idea around the eating disorders. She had never, ever, to the best of our knowledge, ever been a victim of abuse. Her family was from a remote village in Alaska and pretty intact. They loved her. They were desperate to get her help and had taken her to various different places in the States, and nothing had seemed to work. But here we were. Suddenly, she was choosing to eat after a couple days of petting a kitten. And we began in our medical team. We have a medical team here. Our medical team began to look at some things. And one of the things that was discovered was, for whatever reason, she was not secreting human growth hormone. And that was causing a failure to thrive. She was not thriving. And from that point on, what we realized and put together is all that touch was releasing the growth hormone in her and in the kitten. And this kitten was thriving too all of a sudden. And we know now, of course, when there's premature babies, a lot of times they do what we call double bedding, and they're put on a touch schedule, approximately every 15 minutes, a premature baby's picked up, they're stroked, they're touched. We know that touch helps release human growth hormone. And for us, that was a significant point. Excuse me, that the symptoms that we experience in our clients are, we need to be very creative. We're all unique. And we look at individuals as a 1,000-piece puzzle. And we're all about our team, about putting together different pieces to the puzzle. And this little girl really changed our perspective on the care of not only eating disorders, but other issues, that there always is a missing piece. And so what we're seeing today, fast forwarding this a little bit, is our facility treats folks from all over the country. In fact, we have folks that come in from Boise, but come in from all over the country for help for depression and anxiety and addiction. Those are three very common areas that we're seeing over and over and over. Depression, at least that's the presenting issue, anxiety, and anything under addiction heading. So one of the things that we do, and we believe in thinking outside of the box. And so we really do. About 6 years ago, my wife went through chemotherapy. And it was, I have two sons, and it was a tough time for us. She went through chemotherapy, and after all that was over, she developed something we call chemo brain. And the chemotherapy affected short-term memory, ability to concentrate. Chemo's pretty rough. And so she started, amazingly, she started putting together puzzles, 1,000-piece puzzles. And I could never understand, why are you spending time doing puzzles? And she says, well, it's helping my brain come back. Then I really realized that's what we do here at the Center, A Place of Hope. It's helping put together the pieces. Now, our team and how we approach, and how we're going to talk a little bit about addiction, but how we approach this is that we really do believe we got to keep digging and looking for what's each individual's missing pieces to their puzzle. And so on our team, we have psychiatry, and I would say that we have what we would term an orthomolecular or holistic oriented psychiatrist. A little bit rare to find. We have our medical team. We also have 2 naturopathic physicians. Here in the Seattle area, we have a large naturopathic school, and we have 2 naturopaths who are part of our medical team. We also do fitness. We do fitness and assessments on everybody that comes through. We want to know really what we can do with them as far as increasing their movement, their activity. It sounds like for most, the word exercise is not a real positive word, so we call it movement or activity. But we're going to assess. We're going to assess, as I mentioned, sleep. And then we have 2 dietitians on our team. So we're going to look at things like nutrition or lack of nutrition. We're going to look at long-term eating habits and what effect that could be having on a person. And then we've got our addiction counselors. We have our other mental health counselors. And everybody who comes to us, we actually build a team. So if a person's got a lot of, maybe there's trauma, we're going to put them with trauma specialists. We're going to match up teams, excuse me, for each individual. And when we build individual teams, this means everybody here has a little bit different schedule. We're what's called a partial hospital. And so we are providing about 6 to 7 hours a day of care for our clients who are here with their individual teams. I wanted also to share what's an observation. Each Monday and Wednesdays when new individuals start with us. And we do a pretty thorough intake before somebody arrives, and we actually have built their schedule. We've put together plans for them. And right now, the average individual coming in to see us is already on 4 to 5 different medications. Now, they're coming to us a lot of times with complaints around those medications. My 4 or 5 different medications aren't working for me, and something must be missing. And so they're seeking alternatives. I think we are seeing such a large consumers who are looking, what are my alternatives? If the World Health Organization says that depression, the number one, they call it a disability. They say it's the number one disability in the world. Number one disability, that's global. So what we're seeing with depression is skyrocketing, and people are looking for what are alternatives? What's alternatives to treating depression and anxiety and then really addiction? So we're seeing folks already frustrated, medication levels high, and we're seeing what we're going to call a lot of co-addictions or co-occurring disorders. So let me pause for a minute. How's everybody doing?
Great.
Are you guys doing okay?
Yeah. They're all saying yes and great. I don't know if you can hear them.
Okay, just checking in. I don't want to do all the talking. And also, I got to make sure I'm drinking my water. So one of the things that we find is people oftentimes begin addictions because of maybe it's depression or anxiety, and it's subtle and it's sneaky how this happens. I was invited, there's an opiate crisis, of course, that we've been faced in our country. And I was invited on a White House committee or commission to help look at this problem of opiates. And what we know is that a lot of people accidentally step into addiction. It's never purposely planned that I want to become an addict. And whether it's food addiction, and under that I'm going to put sugar addiction, whether it's addictions, medications, we know that so often the anxiety medications like Xanax for folks can create another level of addiction for them. They become addicted to the very medication and create some other issues. But we just find, by and large, people slide into these addictions. Sometimes for food addiction, we call it a process addiction. People slide into oftentimes medication, prescription addiction. And I'm going to add today, I'm going to add digital addiction. The whole area of our digital lives and even social media. I'm going to add certainly sexual addiction. We need to include alcohol, but we probably live in a culture where it's probably fairly easy. You don't have to work too hard to move towards addiction behavior. I mean, it's all pretty readily available. I live in a state where cannabis or marijuana has been made legal, and I will just say we're seeing all kinds of issues. I'm particularly concerned about the developing brain in our 12 to 17-year-old individuals who we're already seeing significant um, issues related to addiction in that age range. It's also an age range that we're concerned about as we look at suicide. The whole area, 12 to 17 is an area of concern. Obviously, our suicide numbers are higher than they've ever been before. And so we've got to look at, well, what's going on? What we've noticed, and this is just in our experience here, anytime addiction goes up, so does depression, so does anxiety, and so does suicide. So, any thoughts about that?
Carly, go ahead.
It could be because of the increase in the digital age. Could that be a factor that you guys have looked at?
Okay, say that one more time. Couldn't quite hear.
Like the increase in like the social media and the digital age on children or the adolescents in that age group. Do you think that could be a big factor in increased addiction, depression, suicide?
I am so glad you mentioned that. Yeah. I'm going to say that social media and what we'll call distractions, digital distractions, can really be a factor. So one of the things we do, and I'll just tell you, for our patients who come in, so today's Tuesday. Yesterday we had a group who just started. We do our welcomes on Monday. And one of the things that we do initially is we take anything with the screen. And we take the screen, so that means laptops, iPads, mobile devices, and the screens go in a locked safe here because we have what we call a technology agreement with our patients. And the technology agreement is interesting because we'll oftentimes check out a device maybe on a Saturday or part of a weekend for individuals, depending on certain issues. But on day 3, so this is day 2, it's really predictable. Probably 80% of our patients who just started on Monday are going to be begging for their devices back tomorrow. And they're going to have a headache. They're going to be irritable. They might have sweaty palms. They're going to feel anxious. They're going to be really experiencing on some level some withdrawal symptoms from their digital devices. And it's so interesting. It's such a predictable pattern. Day 3, people really start to feel it. And they'll say things like, hey, no, I just forgot to do one last email or whatever. When you get past that, here's what's interesting. Because we really do see the physical symptoms. And I know from a diagnostic vantage point, we don't really have a category right now for a digital addiction. We probably will in the future. But I have to tell you, just in our experience, that's real. And I know that for many, the social media and the need for approval-seeking behavior, people say and do things, of course, online that they don't do in person. It's really interesting. Mix alcohol and social media, and what do you usually get? Usually it's not good. Usually you'll get regret. I said or did something, or I sent a picture, or whatever. But I usually do something I regret. It's also interesting. Social media, that age group again of about 12 to 17, they tend to run in if you will, herds. There's always something new. We moved from Facebook. We've now moved, basically, this age group is moving away from Snapchat, and this group is moving into more, it's the live video apps and so forth, which is where a lot of them are ending up. And that's not always ending up with good results. So, yeah. So, subtle addictions. And what we're seeing is probably 40% right now who are with us right now have qualified for a alcohol addiction. So they've come for depression or anxiety, but when they've done their chemical dependency or substance use assessment here, about 40% come up as alcohol dependent. You know, we have substance use dependency, we have substance use abuse, but we're finding about 40% on an average are ending up with an actual diagnosis of dependency. So that's alcohol. And what we find is when we address what's going on in the body physically for a person struggling with addiction, let me just address that. We always do blood work. We always look at things like sleep cycles or lack of it. We're going to also look at, because you know, alcohol decreases the amount of time we spend in REM sleep, hence some of the hangover factors. And we've got to have that REM sleep for a rested, clean brain. We also know that we create nutrient deficiencies. So we're actually, in part of our blood work, we're looking at things like, are there nutrient deficiencies in this person? If a person's had a long history of alcohol use, we almost universally find there are B vitamin nutrients that are deficient. And so we do something, and this is going to be one of our alternative treatments that we blend in. We do something called IV nutrient therapy. And so based upon the person's nutrient deficiencies, one of our doctors mixes up a, if you will, a custom IV bag of maybe it's amino acids, maybe it's B vitamins, vitamin C, whatever it may be. And we actually have an IV room here where we're giving these natural, if you will, vitamin or nutrient IVs. Here's what happens. About day 2 after having one of those IVs, a person, they go, wow, you know, their brain starts to light up a little bit. They start to feel better. But not only do they feel better, cravings tend to really decrease. The vitamin B's and cravings really go hand in hand. And so we've noticed that when we're using the IV nutrient therapy with addictions, the cravings drop substantially, which can be a huge, obviously a huge help, a huge factor. And so we end up doing approximately, for many, about 1 IV nutrient therapy per week as a part of our care.
Dr. Jantz,
yes.
can I ask you, what do you often find is depleted in people suffering from addiction? I think our reading spoke to thiamine deficiency, so B1, vitamin A, possibly C. What do you tend to see in people? And does it differ per type of drug addiction?
Seems like what our doctors are finding is it's almost universally the B vitamins. And what we do know is, of course, our B vitamins, our gut, our intestinal flora manufactures, of course, most of our B vitamins. Isn't that interesting? And so we know that addiction oftentimes disturbs the intestinal flora. And what happens is we're not manufacturing those B vitamins. We know that 90% of our dopamine is manufactured in the gut and travels to the brain via the vagus nerve. And so when we see these addiction histories, it's almost universal that it's the B vitamins. So we're mixing up, if you will, nutrient cocktails for individuals. By the way, I just did a B vitamin IV bag last week. And one of the things that a doctor here looked at my blood work and says, you know, you could use some B vitamins. I said, I'll take them. And so I do most all the different things that we offer here as well. and find it really helpful. We also integrate with our addiction program acupuncture, and nearly universally, our acupuncturist does a lot with the ears and with the acupuncture, and generally it's a very positive report for most folks who are in our addiction recovery program. So we also are going to look at that nutrition. We know that high sugar consumption, if a person who's been struggling, I'm going to use alcohol again as an alcohol addiction, they're going to end up probably with a lot of poor nutrition. Here not long ago, we had an individual here with us, and he had suffered, it was 20 some years of suffering significantly from a depression. He was self-employed and he worked from home, and it was a part of his life that was pretty successful. But he had suffered, and he said, I tried all kinds of different medications. And so then he decided to come, and people come with us. They're here for about 4 weeks usually. And we asked him a few questions, and he said, I've never been asked that before. We asked him, well, what goes in your mouth? What do you eat and drink? 20 years of seeking help for depression, and nobody had ever asked him about diet or nutrition, what he eats, what he doesn't eat. And I'll tell you what we found with this guy. We found that he was drinking upwards to 20 to 24 cups of coffee a day.
Holy cow.
Now, here's what he said. He said, I drink about 2 pots of coffee a day. I said, 2 pots? And he said, well, yeah, it's just the homebrew machine, and it still is like a 24 cups. And he's averaging, anywhere from 20 to 20 or 12 cups, but he's drinking 2 pots a day. So he's averaging 20, 24 cups of coffee a day. Now, nobody had ever asked him what he was putting in his mouth. Do you think he was suffering from some depression and other issues? Severe hypoglycemic issues. All that caffeine was rinsing out his B vitamins, low B vitamins. But he didn't have really an awareness, because he said, it just over time, that's what I ended up drinking. He didn't have an awareness that was really a probable reason for his level of depression and anxiety. Well, it took a little bit of time. He also was no exercise, no real movement in his life. And I actually was the first person to take him and walk him around the block out here. Now I'm near the waterfront. I'm seeing some majestic mountains, and we're in a lovely little area here. And I'm walking him down to through the waterfront, and it takes all he can just to move, because all he had done for so long was sit there in a chair, do his work on his computer, and drink coffee. And so we know that this can create significant issues. Our diet, in this case, it was caffeine. And sometimes we need to think, again, outside the box. There's no amount of medication that was going to change 20 cups of coffee a day. And so his life changed radically. And it was not, in his case, it was not a need for medication. We find that with alcohol consumption, and I would add cannabis, that the natural tendency is the sweets and sugars go way up in consumption. And we know that, that sugar is really not good for the brain. So those are some of the things that we're looking at. So we're seeing the effects of addiction in the physical body. And so when I hear of a class like yours with Dr. Jennifer and the holistic psychiatry and bringing all this together, this is really what we do on a daily basis, where we all are taking our expertise And we're asking ourselves the question, what's the missing pieces to the puzzle here? For some, that addiction, maybe it originated in a trauma. And trauma comes in various forms. One of the books I wrote was on healing the scars of emotional abuse and the effects of emotional abuse in a person's life. That can be traumatic. Obviously, physical or sexual abuse, trauma. And we learned more and more now about the effects of trauma on the early developing brain. And that's why I say I'm concerned about cannabis use in our developing brains and what that does. And I think there's a lot we're still going to be learning about what have done to that developing brain. So, well, those are a few of my thoughts. We years ago, one of our team members was the founder of the American Holistic Medical Association, and he taught us a philosophy that we call the why not. And the why not is, if I can do something for you that has a potential positive effect, and there's really not a downside, why not do it? That's where our IV nutrient therapy comes in. That's where our acupuncture comes in. That's where meeting with our dietitian and even looking, are there food allergies? Are there high sugar content? Is it high caffeine? What is it that a person may be doing unknowingly that's contributing to the depression or anxiety in their life? Now, we believe in, if you will, counseling and traditional counseling. We do that as well. But our goal is to be comprehensive and ask, why not? And what's missing here? What's missing that could make a big difference? All right, tell me what you're thinking before I move on.
Anything? Carly, you have a question?
Well, just with the person that you treated that had talked about drinking that much coffee and caffeine a day, was he already on antidepressants of some sort?
Yes, he was on antidepressants.
So I feel like a lot of people that are on antidepressants try to make up for that, I guess, when they get tired being on the antidepressant, so then they overdrink caffeine, and it just kind of has negative effects.
Mm-hmm.
Absolutely. Absolutely. Yeah. And, we've also noticed, that one addiction leads to the next. And we have a little term that we call dancing between addictions. A person who maybe they've struggled with binge eating, and it really has been an addiction, for food addiction. And then for a while they switch to high consumption of, let's say, wine. And they're switching between addiction. They're dancing between addictions. But always in their life is some addiction. We believe that, we need to, what's core issues here that's causing me to keep engaging in this compulsive behavior? What we know about addiction is it has a predictable outcome. It never takes us where we really want to go. Addiction takes us farther than we ever thought we would go, but it never gets us on the path of where we really want to be in life. And so, but here's the great news. Treatment, I would say whole person treatment, holistic treatment, allows us to take this and get on the right path. We see too many people who, on the average, have done 7 different treatment programs for addiction. 7 different treatment programs. And I just think if we do this in a different way, we can probably lessen that. Now, for some, they made the decisions and they just keep going in and out of treatment, but maybe something was missing that could have really helped. Maybe we could have given them some IV nutrient therapy. Maybe we could have done something to lessen the cravings. But our goal is, again, to look at what's missing and what can we try that can potentially be of help. And so one of the things that we also look at is once they have the fitness assessment here, it's a nurse that we have that does the fitness, we actually plug them into a schedule where they're just a couple blocks away from here. We have an arrangement with a health club where they are put on a schedule of movement. And as odd as you notice, I've been drinking my water. It may seem odd to think, but most of the folks coming in with addiction issues stop drinking water. They're not drinking. They're not drinking water, and their body's very toxic. And so we'll end up just observing. We give everybody a water bottle, and we provide a lot of clean water here. But we're asking that people, as just a simple thing, while they're here, drink water. And so we're always watching their water intake. Now, as simple as that sounds, it helps everything else we do work. Other thoughts?
Yeah, I've got a question for you. So I think that our speaker on Thursday will touch on codependency quite a bit, but I wonder if you could speak at all to the comorbidity of addiction and codependency, but also what people actually experience in codependency, because it does mimic a kind of physiological addiction with withdrawal and physical things that are felt in the body.
Oh, good. What a great topic. One of the things that we look at as well is, and I'm holding here, this is a book I wrote, Am I Codependent? Because most folks struggling with addiction really can ultimately get this. And what we find is this addiction or codependency can be the drug of choice. And it can be the co-addict. It's the person who's enabling. They don't understand that's what they're doing. It's the mom who says, I love, in fact, we just had this. At the welcome, I love my son so much that I will do anything for him. And, we control how much money folks are supposed to have on them. Before she left, and she knew what she was doing, she passed him a wad of $20 bills on the way out of here. And she said, I love him so much, I'll do anything for him. Now, what was she doing with a young man who's had some real cannabis and addiction struggles, and she passes him some money on the way out of here? That's what we're talking about. And it's as though she's compulsed or compelled to do these behaviors that she's calling love. But really, they're not love. And she hasn't really known, how do I truly show love, care, and concern without enabling? So this one is why we also do our best. We have what we call family involvement. We have a person that's assigned to everybody who's to coordinate issues related to family. You can come here, you can do really well here, and man, life can be going a whole different direction. But when you go home and there's a transition to your old environment, there's all those triggers and there's all those people that probably are doing things or enabling us to probably re-engage in addictive behavior. So we do our best, and this can be one of the greatest challenges, but we do our best to address family and family issues as it's related to this, because a lot of family and codependency is obviously it's sabotaging a person's success. A lot of times a person's totally unaware of that at all. So, and we also, there's some pretty good work that's being done in the area of codependency and the brain and similar addiction qualities to the brain. We know that, for example, the PET scans of brains, we know that we can take a binge eater, and I've got brain scans of the binge eater, and I got a brain scan of the cocaine brain. And if you overlay these in the brain, almost all the same areas in the binge eating and the cocaine brain are similar. They're the lit up areas of the brain. And so we know that addiction, whether it's a food addiction, cocaine addiction in this case, and I'm going to be out there a little bit and say, I think you can create relationship and codependency addictions that also have an effect on the brain. And I think there's going to be more that's going to come on that.
I absolutely agree. I mean, I studied addiction at in my PhD and at Stanford, and we would see people coming in not in withdrawal from a substance, but in withdrawal from not being around someone that they were addicted to, and they would shake. I mean, it resembled physiological addiction to a substance, and I had never seen that. But these were veterans, and they were responding this way to their caregivers when they were absent. So,
Yes.
that was interesting.
Yeah. Thank you for sharing that.
Could you walk us through what a day in your clinic looks like for somebody?
Sure. I'm going to reach over here. So when somebody comes to us, we've already, in fact, I do this. I look at our team members and I make sure we have everything matched up based on a person's needs, etc. And we actually build an initial schedule for a person, and we're going to very quickly, we're going to begin. This one does not have a name on it, but I'm going to hold up here a schedule, and where they're going to have medical assessment. We're going to do that right away. So here's somebody. We're going to do this is a naturopathic assessment. This is psychiatric assessment. We're going to begin to get a sense what's happening in their body, chemistries in their body. We want to know that early on, particularly with individuals coming in and having 4 to 5 different medications. So we have medical assistants here, 2 of them, and then we're actually holding people's medications, and they do something called a med check. So we're actually observing them taking their medication when they're coming in. And our main psychiatrist, he talks about actually, if you will, weaning or adjusting he's doing more helping people change their existing medications, in many cases getting off those over time, than actually doing a lot of new prescriptions. So we just find we're in a place where people are already coming in probably from our vantage point with some over medication. So we're helping sort out a lot of that. We also want to know if there's addiction issues, how soon are we going to start those IV nutrient therapy? Some folks need to be hydrated. Now, if they need a medical detox, they've done that before coming to us. We do something called a door-to-door. So they're coming out of maybe a detox, coming directly to us from that, where they're not able to make any stops along the way. So we're also we use groups here as well. A person's going to have a combination of a group schedule, and we use DBT a fair amount. So here we do a DBT orientation. A person gets a 3-ring binder with information, and not everybody, but most all of our clients we put into our DBT, in essence, classes or groups that are daily or 5 days a week. And so we're teaching a lot of emotion regulation and the skills of DBT. We use all the other traditional cognitive behavioral therapy. We're using those kinds of interventions as well. We're using some EMDR for trauma. So we have some of our clinicians who are certified in EMDR. We also are using a fair amount of lifespan integration therapy, kind of a newer trend right now. And we, in this particular case, you can see a person may, we have a couple chefs. So we're actually helping them with food and food prep. So 3 evenings a week, we actually end the day with a cooking class. So it's kind of hopefully a fun way to end the day. Clients get to be a part of a cooking class where they're actually, in many cases, learning to make food fun and healthy again. So we have different types of opportunities. There are about, oh boy, it's 40 different group, sounds like an amazing number, but different group options. And we have different tracks depending on what's going to fit best for the person's needs. For those that want to work in the area of spiritual well-being and faith, we've got faith groups that we make available as well. Most of our clients are going to need to have multiple medical appointments each week. Some of these are coming with some pretty, sometimes they're pretty high degree of complexity to sort out. We also have what we call a higher profile program where we tend to have, well, we have a fair number of sports figures that have come for help or continue to come for help. We've worked with NASCAR drivers, and we do see a fair number of folks who come up from LA for going into our program as well. So,
Oh, LA. Oh boy. How long do people tend to stay there? What's average time?
Yeah, the average, our program we designed for about 4 weeks, but we also know almost half of our clients realize they need a little more time, so they're adding either a week to 2 weeks. So our average stay is really closer to 5 to 6 weeks, just based upon their needs. If it's an eating disorder, they're going to stay a little bit longer. Now we have something called an aftercare coordinator. So before you, excuse me, before you leave here, we've actually put together a transition plan and an aftercare, and we've actually helped people schedule appointments with a provider back at home, maybe somebody they've never seen before. And we've actually put together an aftercare plan for them. And then we also have what we call our alumni program. And our alumni program is just included in what we do. There's no extra cost for it. So when a person is graduating here, our alumni director reaches out to them, and we have weekly phone calls that a person can be a part of. So I can join a phone call with, and I'll maybe it's one of my therapists or team members, and it's a private call that others are on where we're doing, maybe it's anxiety, or we're doing different topics to keep a person anchored in. We also do webinars just for our alumni as well. And then any alumni that needs some extra support, we actually have a mentor program. In a mentor program, we can assign a mentor, so the person has somebody who's been gone from here a year or longer, who they can reach out to. So we find making that transition when a person gets home and getting them past particularly that 6-month mark. If we can get you past 6 months, get you past a year, that really increases our success if we can get you plugged into the alumni.
Yeah. So what, I'm sure that people, different people walk away with different skills, but what skills would you say that people walk away with after your program?
Well, one of the things we want a person, I talked about emotion regulation. If I was to boil it down and make it really simple, the emotions of anger, fear, and guilt. If I'm going to be leaving here, I have to know how to deal in an effective way with anger, hurt, fear, and anxieties. And then I'm going to add guilt or shame. So we've noticed that, if you will, a person who is emotionally growing in emotional intelligence tends to be a person who can manage anger, fear, guilt, and shame in their life. And so those are some of the skills we want you to have. A lot of times it's unresolved hurt and anger, and a person needs to learn how does forgiveness factor into my life? And, am I carrying around a lot of bitterness and resentments? And how is this affecting how I feel about myself and my relationships or my ability to have close, intimate relationships? So we want to equip you to deal with anger, fear, and guilt. We also want you to be practicing great self-care. I want you to continue all the great nutritional and exercise. I want you to continue that self-care. And what does that look like? Um, I think, too, we've got to be equipped to develop. And what does a healthy relationship or healthy relationships look like? And so to have relationship skills.
Yeah.
One final item that I want folks to be on a path for is it's maybe life purpose, mission, meaning. Um, what am I really wanting to do? What's my life goals? What's my life planning? So purpose and mission are another area that we look at. Now, if I'm in the middle of addiction and depression, I can't even think about those things because I don't have any hope for the future. But as we move beyond our issues and we begin in that resolution process, I can be in a better place now to think about what does my future hold? What do I really want for my life? And how am I going to have those healthy relationships I desire? So that's the path we want to see a person go on. Also, to deal with relapse.
Right. Oh, yeah.
How can I be equipped to really deal with triggers, temptations, and I would put people under that heading.
Mhm.
When I go back home and quote, I'm with my old friends, really are they friends? Suddenly I feel triggered to use. Suddenly I feel triggered to drink or eat. I'm getting triggered. And how do I deal with these friends? How do I deal with relapse? What we find is relapsing is a part of healing. It's a part of recovery. But what did I learn from it? The person that I talked to recently who said, I went back home and I knew I shouldn't have been around this person. And before I knew I was using, I knew immediately. And now I made a decision about this relationship and I'm not going to be doing that again. They knew right away. So how am I going to deal with relapse? Because relapse does not equal failure.
Right. Right. Yeah, it's almost inevitable. I mean, so I have a couple more questions. Does anyone have questions, or I'm just gonna go for it? Okay. So, what types of diets do you put people on? We're big into the ketogenic diet these days, and a couple other names come to mind. But what's your general approach?
Yeah. What we begin to do with people, it's interesting how sometimes people, they've lost touch with what's healthy. How do I even make good choices? And you mean that fast food hamburger wasn't the best choice? It's like they've lost touch with what is healthy. And so we do a lot of our dietitians are going to look even at gluten and gluten-free options when it's appropriate. We try not to be, if you will, trendy, but we're teaching people how to make what's the healthiest choice. And that's why we engage them in cooking classes. And we find a lot of folks are confused around food. Am I vegan? Am I vegetarian? What am I? And we look for a food label. And that tells me how I'm supposed to be. So we back away from some of that. And not that we don't support vegetarians, we do. But we don't want to take a label and say this is going to dictate everything you do with your life. I'm going to say that once they're screened for food allergies, and we do see, you tend to crave a lot of the foods you might be allergic to. And I can tell you, generally, most folks decrease greatly sugars and dairy as a result of being here. If it's dairy, obviously a lot of refined foods, and people tend to cut down a great deal on wheat. I can tell you that people report they remove a lot of the wheat and refined processed foods. People just report, I feel better, I sleep better. And so that's part of what we're doing with them. We're helping them make healthy choices. But we noticed overall the decrease in dairy, the decrease in wheat when people are here. Interesting.
That is interesting. Do you guys have questions about diet for him? Anything? No? Okay. Do you often see people with traumatic brain injury that are perhaps in an addictive kind of cycle to self-medicate? Do you see traumatic brain injury at all playing a role in what's going on?
Yes, we do see traumatic brain injury. And how we normally see it, some of the folks who have been professional athletes in contact sports, and I'll tell you, we've had a number of NFL players, and we will have them do various scans. We will have their brain looked at. And I can tell you that most of them have turned to some way to self-medicate in order to deal with that. So oftentimes it's drugs or drinking, but they're looking for a way to self-medicate. And so we do see that, but it's usually come through in our case in working with some of the professional athletes.
Interesting. Okay. What was I going to ask you? Let's see. Any other questions? No. Okay. What about, do you often find that the people that you work with are just missing the basic foundations of what is required to live? I mean, if we think of Maslow's hierarchy, they just don't have that base. They don't have that security. And really, you're helping them establish that.
Yes. Oh, I'll tell you, here's a great example that just happened earlier today. So we believe that the environment's real important. Here, so our offices and the setting, we really do try to keep a really healing, nice environment. We do that in our housing, and our housing is mainly pretty nice condominiums. I can look out over my window and see one of our housing, and they've got views of the water. I mean, this is nice, pretty nice housing. And part of the treatment agreement is you take care of your housing, and you take care. And so we do housing inspections. And I shared some pictures this morning of one of the condos that was.
Oh my God.
To say it was a mess was an understatement. They actually moved all the furniture around, but it was stacks of like garbage and containers and this was amazing how the disarray and that tells us something.
Mm-hmm.
First of all, our treatment director went and got these particular individuals out of a group here and told them that he was going to go over with them and they were going to clean up their housing. And what? They weren't ever used to being accountable to doing dishes, keeping beds made, keeping the environment clean, keeping it healthy. And for us, how you keep your surroundings and your environment can be a clue to some other things that are going on. A chaotic environment could be a very chaotic brain. And so we do look at that. Excuse me. Amazingly, I just got back from Idaho this weekend. Came back with a little cold.
You didn't say hi to me? Good grief. I see how it is. Could you speak at all to how what you do differs from a more typical kind of in-clinic residential situation where there's a main psychiatrist and possibly a psychologist, but a more standard approach where what do they call it, a chemical lobotomy kind of approach versus what you do?
Yeah. Well, we oftentimes see people after they've gone through maybe that route, or they've been in treatment somewhere and they just felt like maybe something was missing. And so we really do, if a person gets here, we so honor them. And that's why their first day, we call it a welcome. We welcome them because it's a big deal to get here. It's a big deal to pack a suitcase and decide I'm going to do something different. It's a big deal. It involves finances, it involves a decision to be away from home. And so we really honor that decision. And people may come with a lot of anxiety, not knowing what to expect. And one of the things that oftentimes we get feedback on is, wow, I couldn't believe that the food was good and healthy. I'm feeling better. And it doesn't feel like a hospital. So we changed the setting. We want to have a healing environment. But I think the thing that comes up the most is I have my own personal team. I have usually it's 4 individuals. I have my own team, and I have my individual sessions, and I have my team. And I might see some other people in some groups, but if it's trauma, we've put a trauma specialist with you, and you've got 6 to 7 hours a day of work. And yeah, you're gonna have a good lunch. We're gonna take care of lunch and a breakfast, and then probably do a cooking class at the end of the day. I say cooking class. It's kind of more of a fun night of you're in with the group and you're doing a meal together, and we have a lot of fun with that. And then there's actually some probably homework and some things that we're assigning you. Everybody gets, depending on their needs, they get a big goodie bag full of things. Once you're here, maybe it's medication, or you want to go out and visit a restaurant, you can. But this is all a per diem. Everything's included. You don't. If there's a book that's helpful, the book's included. So this is a ready-made custom program for a person. But we also have the ability of, if something's for whatever reason not working well, like we need to make it, maybe somebody's not doing good with a particular therapist, we have the ability to change and rebuild schedules. In fact, yesterday I was working with a person just making some schedule changes who I thought would be a better match. And so it's that whole philosophy that we can adapt and do things that whatever's best for the client. Among our staff is the phrase that we constantly use is, okay, what's best for the client here? How do we put the client we're going to care for staff, but we ask the question, what's best for the client? So when we look at what's not best for us, let's stick them in some schedule. It's not that. What's best for the client? And to sincerely do that.
Yeah. Yes. So we're actually at the end of class, but I'd like to give you a chance to say some final words if you'd like to.
Well, I'm just going to end with this. First of all, this is an exciting field, and what Dr. Jennifer is doing, and the future is now. And I also just want to say, we really believe there's hope. We really do believe there's missing pieces to the puzzle. And this is the best time in history for alternatives and getting help that people need. So there's hope.
Thank you so much. Let's give him a hand. Thank you so much. Okay, you and I will be in touch, but thank you again.
You got it.
Bye.